RU58841 versus Pyrilutamide versus Clascoterone. You may have heard of these topical DHT blockers for hair loss, but which one is the best? Most hair loss treatments either lower DHT like finasteride and dutasteride or stimulate growth like minoxidil, but topical androgen receptor blockers are a unique third pathway in the hair loss prevention stack that stops DHT from binding to the androgen receptors in hair follicles in the first place, preventing the subsequent hair loss. But what are the specific DHT or androgen receptor blockers out there, and which is the best one? I'm going to do a comparison of the most prominent options and give my opinion on which one is the best. First is RU58841. RU58841 is a non-steroidal anti-androgen first developed in the 1980s. While clinical trials advanced as far as phase 2, it was discontinued due to unstated reasons, and the results in hair improvement were never formally published, only some safety and mechanism data. To this point, early results showed very good tolerability with limited systemic absorption in animal studies and a binding affinity to the androgen receptor of 1.1 nanomolars compared to DHT, which is 0.25 nanomolar. The lower the number, the stronger the binding affinity, so overall, RU58841 is weaker than DHT, but at high enough concentrations, it can still be effective simply through an overwhelm of the substance. Despite being a discontinued and unapproved treatment, RU58841 has the most amount of anecdotal success from user reports and experiences, whether in combination with finasteride, dutasteride, or minoxidil, or even as a monotherapy. Some users even claim that it caused hair regrowth when typical treatments such as finasteride and minoxidil didn't work. While people generally report no side effects, the downside is that some systemic absorption is still possible in theory. While RU58841 itself breaks down within an hour in the body, limiting its ability to cause downstream impacts, its metabolite RU56279 was observed to stay longer in the body of rats and cause anti-androgenic activity. Although online sources commonly assert a 20 to 24-hour half-life, the primary literature does not explicitly give a half-life for RU56279. The good news is that rat studies showed only a 1% conversion of RU58841 into RU56279, so even if RU58841 does go systemic, the harmful metabolite is likely very limited. Before I go into the next AR blocker, if you like this kind of breakdown where I compare studies, anecdotes, and the mechanisms, please consider subscribing. This channel is focused on practical male glow-up protocols regarding hair, skin, peptides, and general health optimization without the usual surface-level advice. Thanks for your support. Next is Pyrilutamide, also known as KX826. On paper, Pyrilutamide may be the strongest topical androgen receptor blocker on this list. Preclinical binding data commonly cited for Pyrilutamide shows an androgen receptor affinity of around 0.28 nanomolar, on par with DHT, 4 times stronger than RU58841, 180 times stronger than Clascoterone. Since a lower number means stronger binding, Pyrilutamide is arguably the best theoretical receptor affinity of any of the major topical anti-androgens people talk about for hair loss. But receptor binding alone doesn't equal the best real-world hair results. The compound still needs to reach the follicle, stay active long enough, avoid meaningful systemic activity, and work in the real scalp environment. So we need to take a look at Pyrilutamide's clinical and anecdotal results to better understand its efficacy. Earlier phase 2 studies in China and the US showed positive signals for male androgenetic alopecia, and Kintor Pharma, the maker of Pyrilutamide, also reported positive phase 2 data in female androgenetic alopecia. But the biggest update is the latest phase 3 stage readout announced by Kintor in March 2026. In this trial, 666 male androgenetic alopecia patients were enrolled across 26 centers in China and treated for 24 weeks. The 1% twice-daily Pyrilutamide group gained 15.33 non-vellus hairs per square centimeter from baseline, compared to 4.68 hairs per square centimeter in the placebo group, beating placebo by 10.65 hairs per square centimeter. The 0.5% twice-daily group was very similar, gaining 14.46 hairs per square centimeter from baseline and beating placebo by 9.78 hairs per square centimeter. For reference, a normal non-balding head has about 200 hairs per square centimeter, and low-density hair still may have 100 hairs per square centimeter, so 10 additional hairs per square centimeter is only mildly impressive. Safety also looked good in the company-reported data. Kintor reported no drug-related serious adverse effects and no clinically meaningful adverse event differences between the treatment groups and placebo. In an earlier long-term safety trial, they also reported no drug-related sexual dysfunction adverse reactions. On top of that, Pyrilutamide is one of the few AR blocker hair treatments you can legitimately obtain in a high-quality form and for reasonable pricing. Pyrilutamide in its clinical quality is already available through Koshine, Kintor Pharma's official consumer-facing storefront, and Kintor products are also available through Amazon. However, anecdotally from user reports, from sources like Reddit, Pyrilutamide has had relatively underwhelming results, especially as a monotherapy. With RU58841, even though the formal clinical data is unpublished, there are years of anecdotal success stories on the internet, from people saying it stopped and reversed their hair loss, or worked when finasteride was not enough. With pyrilutamide, the online hair loss community does not seem flooded with dramatic pyrilutamide transformations in the same way as RU. Next is Clascoterone, also known as CB0301 or Breezula. Clascoterone is currently already FDA approved under the brand name Winlevi as a 1% active ingredient cream treatment for acne. It stops acne by competing with DHT to bind with androgen receptors in the area it is applied, which is exactly the mechanism to stop hair loss. However, Breezula is a 5% formulation that is currently being trialed specifically for hair loss. In terms of pure binding affinity, Clascoterone does not look as strong as pyrilutamide. The commonly cited androgen receptor affinity for Clascoterone is around 50 nanomolar. That is still anti-androgenic activity, but it's roughly 180 times weaker than pyrilutamide's 0.28 nanomolar binding figure. Just like pyrilutamide, Clascoterone for hair loss has quality phase 3 clinical trial data. Cosmo Pharmaceuticals, the maker of Breezula, reported phase 3 top-line results for Clascoterone 5% topical solution in male androgenic alopecia from 2 studies called Scalp 1 and Scalp 2. Across both trials, 1465 men were randomized, making this one of the largest topical hair loss phase 3 programs ever run. Both studies hit statistically significant endpoints for target area hair count. One study showed a 539 relative improvement versus placebo, and the other showed a 168% relative improvement versus placebo. The safety profile was also reported as comparable to the control group. Then in April 2026, Cosmo released 12-month phase 3 data. The important takeaway was that patients who stayed on Clascoterone achieved a 239% improvement in hair count through month 12, while patients who switched from Clascoterone to a control vehicle after month 6 lost some of their prior gains. Breezula also proved safe with limited to no side effects, although Winlevi could theoretically lead to mild adrenal hormone axis suppression if dosed high enough. For practical intents and purposes, though, this risk is extremely small and basically a non-factor. 539% and 239% improvements may sound impressive, but Cosmo never specified the starting or ending actual hair counts, so a 539% hair count improvement could be 10 hairs to 64 hairs, or just 1 hair to 6 hairs, and the difference matters a lot. Personally, I'm a bit skeptical that they chose to report the relative improvements instead of the actual improvement because it hides the exact functional magnitude of the improvement. You would think that if the results were truly great, the absolute hair counts would be announced instead of just the relative counts. Of course, the problem with Clascoterone currently is access. Breezula itself with 5% Clascoterone is unavailable from Cosmo, and legitimate Clascoterone is only available via Winlevi at 1% concentration. On top of that, Winlevi itself is extremely difficult to get prescribed and covered by insurance in the US, unless you claim that first-line acne treatments such as tretinoin, doxycycline, clindamycin, azelaic acid, and more have already been used. The best method I found to get Clascoterone is through an online telehealth system called Meeskin and to specifically request Winlevi. Winlevi's official site also has an option where you can sign up for a telehealth consultation and potentially get Winlevi prescribed that way. Otherwise, gray market CB0301 is the only source. Just like pyrilutamide, the anecdotal success stories for users of Clascoterone also seem relatively underwhelming compared to the optimistic tones of the clinical trials, and results so far are less impressive than for RU58841. This could, however, also be related to a lower sample size of users due to lower accessibility, but my overall assessment is still that RU performs better. Now, there are a few other androgen blockers worth mentioning, but I would put them in a lower tier than RU58841, pyrilutamide, and Clascoterone. First is Fluridil, also known as Eucapil. Fluridil is an AR blocker designed specifically to have extremely low systemic activity. It is highly hydrophobic and hydrolytically unstable, meaning it breaks down when exposed to water. Since blood is water-based, even if Fluridil enters circulation, it decomposes before it can meaningfully block androgen receptors throughout the body. This way, its activity can be very localized to just the scalp. The problem with Fluridil is its power and practicality. Binding affinity-wise and anecdote-wise, Fluridil does not seem competitive with RU, pyrilutamide, or Clascoterone. It is also relatively expensive and available officially only from Czech manufacturers, and because it degrades in water, it's inconvenient to stack with water-based minoxidil, topical finasteride, topical dutasteride, or other scalp products. Next is topical spironolactone. Spironolactone is a real anti-androgen, and orally, it's commonly used in women for acne and female pattern hair loss. Topically, the goal is to block androgen activity locally in the scalp while avoiding systemic hormone disruption, but I would still not put it in the same tier as RU, pyrilutamide, or Clascoterone. First, it doesn't appear to be as strong from a binding affinity standpoint, being about 77 nanomolars, making it weaker than RU, pyrilutamide, and Clascoterone. Second, spironolactone is not a clean selective androgen receptor blocker. It also interacts with mineralocorticoid pathways and has broader endocrine activity. This is why oral spironolactone can cause side effects like libido issues, erectile dysfunction, gynecomastia, fatigue, dizziness, blood pressure effects, and electrolyte issues, particularly in men. Topical spironolactone does not commonly seem to cause systemic side effects, but for men, the theoretical risk is still not ideal. Then there are the systemic antiandrogens that are taken orally: Pyrilutamide, cyproterone acetate, and flutamide. These are in a completely different category. RU58841, Pyrilutamide, Clascoterone, Fluridil, and topical spironolactone are all trying to block androgen receptors locally in the scalp without shutting down androgen signaling throughout the body. Pyrilutamide, cyproterone acetate, and flutamide are systemic androgens, meaning they purposely block androgen signaling throughout the body. That may make sense in prostate cancer or male to female transitioning, but it makes no sense as a normal male hair loss treatment. Pyrilutamide is the one possible exception, maybe worth mentioning, because it's been explored off-label as a nuclear option for female pattern hair loss. Still, pyrilutamide has also been known to be liver toxic. Flutamide is even less appealing because liver toxicity is an even bigger issue. It has a boxed warning for hepatic injury, including rare liver failure and death. For hair loss, that risk-reward profile is frankly terrible. Cyproterone acetate is pretty much the same liver toxic, systemic androgen shutdown story. With that breakdown, what do I think are the most effective topical AR blockers currently available? If I had to rank them, I'd go this order. First is RU58841, then Pyrilutamide, Clascoterone, topical spironolactone, and then lastly Fluridil. Despite being exclusively a gray market substance and no published clinical trial results, RU58841 was at least proven effective enough to advance the phase 2 trials and has had decades of user success stories of significant hair regrowth. The biggest pharmacokinetics downside is that clinical evidence for limited systemic absorption only exists in animal models, whereas the other topicals have human evidence to support this. Anecdotal user experience still suggests that systemic absorption is limited. Pyrilutamide is the next best option in my opinion because it has numerous and large phase 3 trials with positive results, has the best mechanistic affinity for the androgen receptor, and is legitimately accessible. However, its anecdotal success is less compared to RU58841, which is why it still loses out to it. Clascoterone seems to be on a similar tier to Pyrilutamide with comparable anecdotal success or lack thereof. However, the clinical results seem a bit less impressive to me, and accessibility is a major barrier for Clascoterone, even on the gray market. Topical spironolactone is in 4th place here because it's simply not selective for the scalp androgen receptors and has weaker binding affinity. Finally, Fluridil is in last place because it has the weakest binding affinity of all and precludes the ability to stack other topicals on top of it, making adherence to a topical hair loss regimen more difficult. Thanks for watching my guide on topical androgen blockers for hair loss. If you want more hair loss and glow up breakdowns like this, where I compare the actual evidence, the anecdotes, and what's practical to use, please consider subscribing. I'm going to keep covering the treatments that most dermatologists either don't know about or won't talk about honestly.